Okay. Okay, so as Dr. Martin said, we're excited to give all our updates for April and go ahead and getting right into it. Um, this past month we had Women's Health Research Day at VCU, and we got to take some new lab pictures, which was super exciting. And we had some of our lab members present. So here's Ellen with her poster here. And then here's AB and the better poster here in another lab photo. And so this past month, we found out that for the 4th year in a row, Dr. Martin was ranked top docs for addiction medicine, which is no surprise, but congrats. And next, we have our manuscripts that are in review. AB has 3 manuscripts in review. Gus got to revise and submit. Congrats. He's working on that now. And then Michelle just submitted a paper that's under review. And then we have some recently accepted manuscripts, super exciting. So Taylor just got her paper accepted. And then Dr. Martin had 2 of her papers accepted. And here's a screenshot of Taylor's paper. Okay. And here's our promotion for our social media. If you are interested in giving us a follow on Twitter. And we also have a YouTube channel if you are interested in keeping up with our lab meetings. If you ever miss one, want to catch up, feel free to give us a follow or check us out. And next, we're going to get into our active studies. So first, we're going to talk about Project Better, which provides a theoretically grounded assessment of feasibility and acceptability of a new technology-delivered educational intervention for pregnant and parenting people receiving medication for opioid use disorder. So this study, recruitment is complete and chart abstractions are ongoing. There was a total of 37 participants, and AB leads this study. And then here are the better manuscripts. We have one of AB's that is currently in review. And then here are some of the better presentations. Next, we're getting into Project SORT, which you're going to hear more about that data a little bit later from Victoria. But this study is investigating the relationship between sleep and opioid use disorder recovery. So Michelle leads this study, and chart abstractions are ongoing, and there were 211 participants. And then here are some of the SORT manuscripts. Congrats to Hannah and Susie for getting a revise and submit. And then here are some of the SORT presentations. And next we have the OB Motivate Patient Registry, which is an ongoing record to track clinical outcomes of our pregnant and postpartum seeking patients who are receiving addiction treatment with the OB Motivate Clinic. And there are 144 participants, and AB and I co-lead this study. And then here are the registry manuscripts. And here are our registry poster presentations. Next, we have postpartum recovery, which this study compares biopsychosocial factors such as pain, mood, impulsivity, and maternal infant attachment compared during the 3rd trimester of pregnancy and within 6 weeks postpartum between women with opioid use disorder. So chart reviews are complete. follow-up visits are complete, and AB leads this study. And then here are some poster presentations. And manuscript. Next, we have Project Castle, which is currently in production, but this is a computerized intervention that educates medical professionals and pre-medical professionals on substance use disorder stigma. And I lead this project. And here is our Castle poster presentation. And next, we have our educational studies. So the most recent study we have going on is the clinical research curriculum study, which is led by Dr. Madison Simpson. And this study is just creating a clinical research curriculum for medical students. And then here are some of our posters for the educational studies. And here are the manuscripts. And next we have the perinatal BUP database, which recruitment and the primary analysis are complete for this study, but the secondary analysis is still ongoing, and this describes trends in buprenorphine dosing during pregnancy and up to 12 months postpartum. And there were 300 participants. And then here are our poster presentations. And here are the manuscripts. And then here is our exciting pending research support. We hope to have some good news very soon coming our way. And we have our next lab meeting scheduled. It's May 29th, and Michelle will be presenting some more qualitative data from the SORT study. And then if you have any questions or any updates, please feel free to reach out to me.
Awesome. Thank you, Lilia. And Lilia did not announce her big news that she got into graduate school. So exciting news for Lilia that she will be a clinical psychologist one day. So we're all really excited for her. Yes. If you know anyone who's looking for a job, also let us know as we will be looking for someone to come on and train with Lilia with everything that she has going on to continue the work that she is really started and really taken forward. So she will not be leaving us yet, a little bit longer, but we're really excited for her. So congratulations again, Lilia. Awesome. Well, great. So many good news things. And that's nice pictures, which I was very happy about at Women's Health Research Day. Thank you everyone for doing that. So now I'm going to hand things over to Victoria, and she's going to do her research in progress presentation. Victoria, before you start, just for people who don't know you, just tell a little bit about yourself and how you landed here, what etc. And then everyone will be looking forward to any feedback that you have on her presentation as we are looking to define the next steps for this project, as well as for Victoria, who will be presenting this in just a couple weeks.
Great. So hi, everyone. Oh, can you hear me okay? Okay. My name is Victoria. I'm a third-year medical student, new third-year medical student. We just started rotation a month ago. So I joined Dr. Martin's lab December of my first year, so 2022. So it's been a year now, and I spend the summer working with Michelle at the Motivate Clinic, collecting data for SORT. But today I'm actually presenting on data that Michelle started actually, but we kind of expanded. So thank you everyone who make out to my talk on post-traumatic stress and the pregnancy to postpartum transition among birthing people with OUD. Okay. So postpartum mental health is an increasing public health concern due to the impact it can have on not only maternal outcomes, but infant outcomes as well. In fact, maternal mortality owing to behavioral health issues remains a leading cause of death, with rates of substance use and mental illness on the rise. We often think about postpartum mental health in the context of postpartum depression and anxiety, but the childbirth experience itself can be a very big component of the postpartum mental health. The childbirth experience can be distressing to postpartum people and sometimes even traumatic. And a negative birth experience can cause psychological distress and intense fear in the short term and increase the risk of mental health conditions such as anxiety, depression, and post-traumatic stress disorder or PTSD in the longer term. And so what post-traumatic stress might look like immediately postpartum include the parent feeling or expressing a lot of anger at the medical staff, being very alert to monitors and alarms, and avoiding bonding experiences with the baby. And evidently, this is a prevalent issue in that up to 4 to 6% of women develop PTSD following childbirth. And so this and how this might impact a population of interest, which is birthing people with opioid use disorder who often experience unique challenges with labor and delivery. Recent study has found that pregnant and postpartum individuals were not optimally treated for their substance use disorder or mental health, despite having risk factors acknowledged in their medical records. And so the post-traumatic stress itself may trigger substance use and overdose in this population. And these stressful experiences may also disrupt mother-infant diet bonding, leading to varied attachment styles and suboptimal infant development. So despite the increase in opiate use in the US impacting pregnant and parenting people who are a particularly vulnerable population, prevalence and impacts of traumatic stress in the pregnancy to postpartum transition for birthing people with OUD have not been investigated. So the objectives of this study is to first characterize post-traumatic stress after birth among people in OUD treatment with buprenorphine, and then also to describe postpartum maternal mental, physical health, and caretaking factors among those with and without post-traumatic stress. So to do this study, we conducted an a priori secondary analysis from the postpartum recovery study, which follows pregnant women in outpatient OUD treatment for 1 year postpartum. And we analyzed survey data at third trimester, 2 days, and 2 weeks postpartum. The inclusion criteria for the study are that participants must be 18 or older in age, currently on buprenorphine for opioid use disorder, and were 28 to 40 weeks of gestational age, so the third trimester period. Our primary outcome is to use the PCLC, which is the PTSD checklist civilian, to screen for post-traumatic stress in participants. It ranges from 17 to 85, and scores of greater than 29 indicates post-traumatic stress. Some other measures that were collected via survey data were MAI, which is the maternal attachment inventory, PCC, which measures perceived control during childbirth, was satisfactory with labor and pain relief, BSCS, which stands for Brief Substance Craving Scale, PROMIS, which is a measure for anxiety and depressive symptoms. And we also asked participants some child welfare questions, such as, since your baby was born, have you been involved with Child Protective Services? And lastly, we asked if participants were breastfeeding or pumping milk for the baby. So we had a sample size of 19, and based on their score on the PCLC screening, our data were described in two groups, the individuals with post-traumatic stress versus no post-traumatic stress. But due to our small sample size, there was no statistical test performed. So this is definitely something to keep in mind that we're just describing the data here. So among our 19 participants, nearly half screened positive for post-traumatic stress after birth. So here's a table to further describe the characteristics of our sample. The two tables have the same heading. They're technically one giant table, but I just chopped them in half so that we can see the data better. So the numbers are in percentages, except for age and the PROMIS score. Our participants are predominantly white, unemployed, and married. Mean age for the post-traumatic stress group was 27 and 32 for the no post-traumatic stress group. Anxiety and depression symptoms assessed at 2 days postpartum show that people in the post-traumatic stress group scored higher as compared to people with no post-traumatic stress. When we look at social determinants of health, post-traumatic stress group had a slightly higher percentage of people reporting food security, but all of the participants in the no post-traumatic stress group reported stable housing and adequate access to medical care. Interestingly, all of the participants in the post-traumatic stress group reported partner involvement in the mom's and baby's life, which is not the case for the post-traumatic stress group. But I think it's also important to keep in mind that we often think about partner involvement as a positive thing in general, but we kind of have to consider as well whether that is the case sometimes when partner involvement itself can be a stressor. So on the top of my head, I don't believe that that was something that was assessed, like whether birthing parent perceived partner involvement as something that is positive or not. But I just thought that that was something to consider while looking at this data. And then for trauma history, we grouped previous traumatic experience that are unrelated to childbirth into these three general categories: crime, general disaster, and physical assault. Interestingly, no post-traumatic stress group report higher percentage of experiencing these events compared to the post-traumatic stress group. So next, we're going to look at the data in another way. These measures were all assessed at 2 weeks postpartum, and we saw that when anxiety and depressive symptoms were reassessed, post-traumatic stress group in blue still reported a higher level of anxiety and depression compared to no post-traumatic stress group, although the scores did decrease slightly compared to when they were assessed 2 days postpartum. The no post-traumatic stress group reported a higher satisfaction with pain management and reduced cravings. The two groups scored similar in terms of level of maternal attachment and perceived control in childbirth. But it's worth noting again that for maternal attachment inventory, a lower score indicates higher attachment. So the no post-traumatic stress group technically has a slightly stronger attachment, with score being 27 versus 28 in the other group. And then looking at child welfare involvement, we saw that a higher percentage of birthing parents in the post-traumatic stress group report Child Protective Services involvement. And interestingly, a much higher percentage of individuals in the post-traumatic stress group report that they're breastfeeding or pumping milk for the baby. So in conclusion, we saw that nearly half of our participants receiving buprenorphine for opioid use disorder experienced post-traumatic symptoms after birth. Through our interviews with the birthing parents, we found that 2/3 of parents identified an infant medical issue or traumatic birth experience as the postpartum event triggering their post-traumatic stress symptoms. So ultimately, studies of larger samples and qualitative investigations are needed to further understand these experiences and their unique intersections with OUD treatment and recovery. And so like, what about these experiences made them traumatic so that clinically we can improve trauma-informed care strategies? So before I open up for questions, I just want to thank Dr. Martin, Michelle, Annabeth, Amy, and Lilia for their support and encouragement on my research. And then for questions, I'm just going to leave all my results here for easier presentation.
Great job, Victoria. Good job synthesizing all of that. I can say that the most, not interesting, but the thing that kind of stood out to me the most when we were first starting this project, like back in the day, was just the what you put in your last slide as the reasons that people cited for the post-traumatic stress, which was you said infant medical issues and the childbirth experience. So that, just putting numbers with that, which is something we unfortunately see clinically pretty commonly, is very powerful and can bring a lot of light to opportunities for doing a better job, right? And how we because those are two things that happen at the interface with the healthcare system, right? The infant medical related things and childbirth. Those are both not things that are happening outside the walls of the hospital. Those are two things that are happening inside the walls where we have a little more control, right, over what we do, at least as providers, and how the systems work. So that's what got, when this first started, I'm just going to say this, that was the most interesting part to me. So I'm happy to see this taken a little bit farther to take a look at how that has correlated with the outcomes that we did have available in this small data set. So I'll open it up now for any comments or questions that people have for Victoria's project.
I have a couple like research methodology type questions, if you don't mind. So you used was it the PCL5 for
civilians?
Yeah. So when was that interview conducted? Was it like during the postpartum period?
I believe it was third trimester interview.
So none of them were actually interviewed. They were all survey, just self-reported. And so if the baseline one, I can't remember, it's been a while, Victoria, since we did these analyses, but if it's based on the baseline, then that was during the third trimester of pregnancy. And then the postpartum data was mostly at the 2-week point, right, Victoria?
Mm-hmm.
Does that answer your question, Madison?
Yeah. I was just wondering, based on, you're looking at 2 different time points postpartum, and I was just curious whether how people score on this measure would change throughout the postpartum period. Maybe like as a little bit of time has passed since the birth, and whether that would, affect the type of results that you're seeing. So I was just curious about that. And then I was also wondering, so you have your post-traumatic stress group and the no post-traumatic stress group. Was the no post-traumatic stress group, did these people score like a 0 on your assessment? Or was it more of like a low post-traumatic stress versus high post-traumatic stress? Or where did you find that cutoff, and how did you rationalize that distinction?
I think so, using sorry, let me pull up the screening tool. So using this is the original questionnaire for PCLC, and then the cutoff was 29, and that was validated in some other studies to be the cutoff for post-traumatic stress versus no post-traumatic stress. I did not look specifically at where individual participants scored, but we kind of just use that cutoff for like a yes or no, and then like divide them into the groups.
Gotcha. Yeah, it could be interesting to add maybe just as a row in your table as just the median or mean score on this PTSD checklist between the two groups, just to give people a little bit of an idea of where people are scoring on this continuum.
I would also add, I think that's a great idea, Madison. And then also thinking about if the no post-traumatic stress group is not really a no, right? If they're just, then maybe, I know the wording is based on prior literature, but we can switch things up to say high and low potentially, or something different rather than yes and no, given when you put that in. That's a good idea.
Yeah, I can't remember what the wording is for this, but a lot of times, Victoria, it's like meets clinical like cutoff versus not or something. Because yeah, it's not fully accurate to say no. Some of them might have no, but some of them definitely have some of the symptoms.
Yeah. And also this is a screening tool. It's not like diagnostic. So this is used just for like a first pass screening. And then clinically, I think it's important that we do follow up on any, I guess, participants who does have some score of the symptoms to further investigate, you know, what's going on.
Victoria, I thought this was really awesome. I had a quick question on just how you sort of determined the timings that you were using, like why 2 days postpartum and 2 weeks postpartum were kind of the timeframes you were looking at instead of looking maybe a little bit further out from the delivery.
So the postpartum recovery project itself, like the data were 2 days to 2 weeks postpartum. I didn't choose those cutoff, but I think it is important that it'll be interesting to see like further out. I mean, ideally, like 1 year postpartum would be ideal, just to kind of like follow that up. I would imagine, I mean, 2 days is like immediately postpartum, right? That's like when they like just experienced the childbirth. 2 weeks is a little bit further out. And I feel like personally, I've seen like pregnant individuals, at least like EPDS score, like change dramatically, like 2 days versus 2 weeks. Sorry, that's like a measure for like depression. That score like changed dramatically, like 2 days versus 2 weeks. So I think that might be a rationale for using that 2 weeks. I don't know if Annabeth might have like, you know, better insight to why those time points are choose, but that was just my guess.
Yeah, sure. So part of the reason for when we were setting up the study, the parent study, was so that we could capture data while people were still in the hospital. And we were, when we set up the study, it was pre-COVID. So we thought we were going to be doing all of this in person. And so that was like a time point that we could catch people and get at least some data rather than no data. Same thing for at the 2-week point. That's a common check point time for, you know, postpartum moms in the OB Motivate clinic or postpartum people to come into the clinic. So I think originally it was set up with kind of those appointments in mind and those touch points with healthcare. And so the other piece of that is it's a time of intervention that's a little bit easier. So like if we know that people are having high rates of symptoms at 2 days and at 2 weeks, even if it's going to fade over time, that's still a point where we could offer assistance and provide help if we know that, because they're more likely to be interfacing with healthcare at that point. As far as the research piece, we had a lot of drop off over time, as you might imagine, like following these participants for a year. So we had the most participation at 2 days and 2 weeks postpartum compared to 6 months or a year postpartum. So the numbers just got smaller and smaller. So those were kind of all of the reasons that we focused on the 2 days and the 2 weeks postpartum. I think to actually meet like a PTSD criteria, I think you have to have symptoms for at least 30 days or about a month. And so this is like an early intervention point. And then if we were to look at another time, I think looking around 4 weeks would be helpful for like an actual diagnosis of PTSD. But yeah, those are my thoughts on it.
Yeah, that makes a lot of sense. Thank you.
Mhm. Victoria, I had a couple comments kind of triggered by what you were talking about. One with the partners, and I do think that's a good point that not all partner involvement, particularly for the sample, is helpful. We do have I don't think it was the HITS questionnaire, but there was some intimate partner violence questions, and they do ask specifically about the partner. So if you wanted to add that in as just another descriptive piece, you could potentially look at, how many we could see how many said their partners were involved and then how many it looked like were not particularly helpful or that they were dealing with violence also. So we could kind of narrow that down and get a little more information about that. And then I was also thinking that the people who participated in this study to begin with were doing fairly well in their recovery because they were like signing up for this kind of long study. And then even more so for the people who are still participating postpartum. And even among that like sample that we think of as like doing particularly well had this high rate of symptoms. So I think it's just something to keep in mind when like generalizing about this sample is rates are probably worse among the like clinic wide sample. So just a thought that I had about it.
Yeah, thank you. That's a really good point.
Does anyone else have any other comments or questions for Victoria?
I have kind of a question for the group, I guess, as someone who's definitely not a clinician. Some of these stressful events that are happening during childbirth, like you said, like infant medical issues and stuff like that. As a healthcare provider, it seems like, you are in a position to help the birthing person deal with that, but it's not really something that's within your control. And like, unfortunately, sometimes bad things do happen. So obviously you want to minimize the stress for the birthing person. But it might not be completely within your capacity. So is this data kind of suggesting, I guess, like looking forward into how we can use this in the clinic, is this suggesting that this is something that we need to screen for more often? And then what types of like treatments or resources are available to women who or birthing people who do have experienced post-traumatic stress during the birthing process?
Well, I just stepped into the clinical world. I'm on ambulatory, so I actually haven't even stepped into the hospital for inpatient yet. But I think to begin with, like this is something that kind of like brings awareness that this is like happening, because I think a lot of times, even though it's indicated that they have mental health concerns, like that's kind of like overlooked or not kind of like be set to priority during their hospital state treatments. And so this is kind of like once we do the screening, and I assume, like I feel like ideally it will be nice to do it during the third trimester, and then again, immediately after birth, and just to like see as a continuum like how they score on those measures. And I think Dr. Martin actually sent me a paper on like that more validated like PCL5 now that just came out last year. Because I think initially we're using the civilian because PCL5 is more tailored to veterans, but actually this paper validated measure for like a good tool for birthing parents after childbirth as well. So I would think that this can be like a tool that we can use to raise awareness among clinical or like physicians or clinical staff to be on the lookout for those symptoms, and also like for those triggering events, such that when they do have an infant medical issue like that, those PTSD like symptoms are like on the radar for them to look out for during their treatment. But I'm curious to to see what other people think.
Yeah, I would add on, and anyone else is, there's a lot of clinicians on the call, but there's a cascade of care for mental health. And if you work backwards, right, then if you identify someone who has, let's say, PTSD in the postpartum period, at the very end of that cascade of care, that person should get evidence-based treatments. Unfortunately, those are just not at our disposal in the OB world, right? So if someone comes in, they let's say they even got diagnosed with it, let alone just a screen positive, getting them set up with evidence-based behavioral and/or pharmacologic treatments. I don't have a psychiatrist and a psychologist always in clinic, right then. We have more resources at OB Motivate. We're like a super small component of the even just the rest of the VCU OB clinics. So I think this data that came out from this paper last year, just really heightening awareness about PTSD, just kind of staying focused at least on one condition, is just adding numbers to say we just need to increase access. When I say access, it's not just the access to providers. I mean, just having more providers that treat these things, but also just making it actually accessible to patients. And a postpartum patient, they have a lot of things going on, so having a patient screen positive in their OB clinic and then giving them a handout or saying, go to this website to find a therapist, like that's not access, right? So there's just but that's kind of where we're at. So there's just a long way to go in improving what access actually should mean for these things. So, and I would say of all the perinatal, mental health conditions, PTSD is probably one of the ones that's looked at the least, I would say. We have had increasing attention to depression, anxiety, more mood disorders. Again, we're still not there. There's a huge gap along each level of the cascade of care. But at least that has started getting better in recent years. But PTSD has kind of been ignored in all of that. So I think that has been a topic that's gotten some more attention just in the last year.
If Michelle is on the call and available, I don't know. I'll call her out for just a minute, but I know that she does work in the NICU with lots of parents. And so that's a way they have lots of strategies that can help intervene at like this post-traumatic stress level, whether it's finding ways to help parents come and visit because they're avoiding being there because of their post-traumatic stress, or, interacting more with the baby, like helping the healthcare providers, like teach the parent how to do something rather than coming in and doing it. And really walking the parent through it. So there's lots of little strategies that if we knew about these kinds of things, that a clinical psychologist or a social worker, any of those mental health care providers could help implement.
Yes, I'm here. I'm so sorry. I must have stepped away for a second when you called me out. But I am happy to answer that question, whatever it was. But absolutely, I think in the NICU, as a therapist, most of what I see is postpartum PTSD, because a lot of times in the NICU, it's, the pregnancies are healthy and then things kind of happen in the childbirth and postpartum process, and a NICU admission can be really unexpected. And that can be a really traumatic thing. And not only that, but in the NICU particularly, it's kind of like an ongoing trauma because they have to go to the NICU every day to see their babies and kind of the source of that trauma and pain. So it's a lot of like PTSD treatment is like, not prolonged exposure therapy or some of the things that we think about as psychologists for PTSD. But it's kind of like processing and self-compassion and being gentle with, themselves with all the triggers and all the sounds. The beeping of the monitors can be particularly stressful. So And there's so many women in the NICU with substance use disorders in recovery. So it provides a really interesting intersection for me. But that was a long way to say that, yeah, lots of interesting treatments and a lot of collaboration with the NICU nurses, the social workers, the providers. It's very cross-disciplinary.
That answers the question, Michelle. Madison had just asked like kind of what we do clinically. So I just wanted you to talk about your NICU experience.
Perfect. Okay, Madison, I hope I answered that question.
Yeah, it's great to hear that there are like resources available, and it sounds like especially in the NICU, that's something that's, people are paying attention to, but it also sounds like, this is something that we need to look beyond the NICU for all types of different types of traumatic birth experiences and raise awareness on and increase that collaboration with people who are prepared to do this type of counseling and mental health work.
Yeah, absolutely.
And just to give a shout out for my current ambulatory clinic, I'm at the Jackson Clinic for Ambulatory Psychiatry. And so I work with Dr. Bushra Shah a lot for her women's health clinic. And she has like a OB clinic on Thursday mornings. I think she sees patients at the Jackson Clinic. And so I've seen a lot of patients that are like 2 days after they got discharged from the hospital, or like a couple weeks after, and then she sees them for like less PTSD, but a lot of depression for sure. And they might have previous traumatic birth experience from like a prior childbirth. And so it was really interesting to see the amount of resources those birthing parents have. So it's been really, really cool to see. And sometimes I see like the OB physicians that are at VCU like refer them to Dr. Shah's clinic, and it's really cool to see the intersection of care.
Hi, Victoria. I just wanted to say your presentation was really great. This is such an interesting topic too. I just had a quick question for you. Did you analyze, and I'm sorry if I missed this, but did you analyze if it was the participant's first baby or like what number pregnancy it was? Because I wonder if that could, play a part, just because I would imagine the first baby is probably a little bit more harder to manage than subsequent ones.
Yeah, thank you for the question. I'm actually not sure. I didn't see. Annabeth, is that on like the questionnaire?
I'm not sure if it's on the survey, but we do have it in the chart abstraction, which that part was in the works until recently. So that's another thing that we should be able to add in pretty easily because that has been completed at this point.
But yeah, that's a great idea. I would imagine. Yeah, that's something interesting to look at.
I actually don't know if I can really confidently hypothesize which way that would go though, Swati. Like maybe someone had a traumatic birth in the past and that might put them more prone at risk for things to kind of be brought up again versus what you said. I don't know. I feel like it could go both ways. So that would be something when we do the qualitative work, really delving into, gosh, are these things that pre-existed and this childbirth, brought that up a little bit more? Would think of better ways to say that with my psychologist colleagues, or are these things that were more de novo and like just like what Michelle was talking about, like, gosh, I didn't see this coming at all, like this NICU stay. Kind of delving into those things a little bit more to tease it apart so we can better identify, the contributing factors to this in the postpartum period.
Yeah, and also just looking at like the trauma history, obviously this is such a small sample and no like definitive conclusion can be drawn from this, but I was looking at like the no post-traumatic stress, this group had like reported higher frequency of experiencing like trauma history. And so that kind of made me think like, do experiencing those trauma made the post-traumatic stress group like more resilient to like a traumatic birth somehow? But again, this is very small sample, so can't really say for sure. But yeah, that's something to think about.
Yeah, I don't know the literature on this well, but I think that's actually the opposite of what we expect. I think people who have a trauma history tend to have more of a traumatic stress like reaction to what someone else might not like have the same experience and not view it as a trauma and have that response. I don't know if Michelle knows more about that, but that there's a word for it, or like a phrase for it, but I can't remember what it is.
I also can't remember what it is, but it is like something about like the re-traumatization, like it can happen again and it can trigger like those experiences. I tell a lot of my Nikki families like, the body keeps the score. And so when you're in like an environment that can really send you back to a place. So when you're going through the childbirth experience, if you've had trauma around like bodily autonomy specifically, and kind of that loss of bodily autonomy can like really come back really strongly in the childbirth experience, particularly with like an unexpected nature of it. So yeah, definitely more I've experienced just like anecdotally, but I think the literature also supports more of what Annabeth was saying.
Well, this has been a great discussion. Does anyone else have any other comments? Well, great. This has been great. Lots of feedback for Victoria and also for this project when we hopefully are going to take this to the next stage with some qualitative work later on. So it's wonderful, and good luck to Victoria when she presents in a couple weeks at ACOG too. Well, thank you everyone for joining for our lab meeting, and we will look forward to seeing everyone May 29th, I think is what Lilia said. Okay, ironically, it's the same day as today, just May 29th next month. If you have any questions about anything, just reach out to Lilia or me, and I'll see you guys all soon. Thank you.